recorded. At this time, all participants are in a listen-only mode. Those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Christine Quinn, Director of Programs at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks very much, Val. Hello and welcome, and thank you for joining us for this information webinar for the Embedding Palliative Approaches to Care, or EPAC, Spread Collaborative. We're so pleased to have more than 60 people who registered for the webinar today. And as you can see from the map, we have participants literally from coast to coast. We're also pleased to provide simultaneous interpretation for our webinar today. Now, this may result in a few quick pauses in the dialogue. And we do invite you to participate in our chat box in either official language. As Val said, my name is Christine Quinn, and I'm the Director of Programs here at CFHI. And I'd like to take a moment to introduce you to the other members of the collaborative who will be speaking today. Jane Webley is the Regional Lead End of Life at Vancouver Coastal Health and developed the EPAC model. Jane is an experienced clinician, manager, and leader in palliative care and in long-term care. Elaine Graves is the Senior Improvement Lead at CFHI and is responsible for leading the development and implementation of this collaborative. Participating teams will get to know her quite well over the course of the collaborative. And helping us in studio today, we have Lauren Harmonlaw. You will get, Elaine will be your primary point of contact if you need support over the course of the collaborative. On behalf of all the presenters, welcome. So the main objectives today really are to provide you with an overview of CFHI, so who we are, what we do, and of course an overview of the EPAC model and the Spread Collaborative itself, and then to answer any questions that you may have about the model and the collaborative. Now, some of you on the call today have participated in a CFHI collaborative before, but those of you who have not worked with us previously will provide a little bit of an overview. CFHI identifies proven healthcare innovations and accelerates their spread across Canada by helping organizations to adapt, implement, and measure solutions that improve the patient experience and healthcare outcomes. We unleash innovations that have been co-designed with patients, families, and we work shoulder to shoulder with organizations, providers, patients, families, and Indigenous communities to improve the healthcare for all Canadians. In particular, our collaboratives bring together interprofessional teams. They offer innovations that tackle a common healthcare issue. They're team-based with shared learning, and we provide the support needed to kickstart sustainable improvement at the service delivery level. So that means things like seed funding, evidence-informed resources and curriculum, and of course, coaching to support implementation. Our strategic quality improvement approach to collaboration influences and accelerates health system transformation. Through environmental scanning and engaging with our key stakeholders, we identify and develop programs that are ready to spread. And what we do is we build capacity for senior leaders to help create improvement-capable environments. We enable meaningful patient and provider engagement. We support the alignment of evidence, incentives, and culture for improvement and innovation. And then we work with the coalitions of the willing to drive to large-scale change. So now let's take a closer look at the EPAC model and the collaborative. But before we begin, we want to make sure that we have an opportunity to address any questions you have. So we're going to open a poll and ask that you share with us any questions you have today that will help you decide whether or not this Spread Collaborative is a good fit for you. So I'll give you a couple of minutes to type in your questions, and then we'll take note of these and try to make sure we answer as many of them as possible throughout today's webinar. Just give you a couple of moments to type some questions. As I said, over the course of the webinar, we will really try to make sure we answer any questions that you have, but we will also put together a little bit of a question and answer, a Q&A document that has some of those frequently asked questions that people have about joining the CFHI Collaborative, as well as any of the specific ones here, and we'll make sure that we provide you with that. So just leave the poll open for a couple more moments to give people a chance to type. But if we move on, you can please, I encourage you throughout the course of the webinar to use the chat box, and you'll see that in the lower right-hand corner of your screen. You can ask your questions in either language, and as I said, we'll be keeping track of that over the course of the collaborative. So I'm going to now hand it over to Jane, who's going to walk you through the EPAC model, its impact on resident family care, and of course on the care team's experience of providing palliative and end-of-life care. Thank you. Over to you, Jane.
Hi, thanks so much, Christine. Good morning. Can everybody hear me all right? Yeah?
Yep.
Yeah, so I just want a couple of acknowledgements before I actually go into describing the model. The DAISY prototype that preceded EPES was initiated at one site. Initially, we had tried to implement it at a site back in 2010 with some help from a colleague manager of Evergreen House on the North Shore. Wasn't very successful, but we did then move to another site and were fortunate enough to make some changes that were recognized by the BC Patient and Safety Quality Council, who gave us an award, and with that money we were able to buy pins, posters, books to spread that to 12 other sites. And then following the success of those other 12 sites, we then were very fortunate to have a foundation gift from via VGH and UBC to spread the initiative to a total of 48 sites. I also want to acknowledge the collaboration that took place throughout Vancouver Coastal Health with the divisions of family practice, and to tell you there are no conflicts of interest. So a little bit about our organizational context. We are quite a diverse health authority. We have 48 sites, 13 owned and operated, and 35 contracted sites. We have 6 sites that are rural for 442 beds, and then in urban centers we have 5,389 beds. So quite a diverse population. We have several sites that are purely Chinese speaking. We have German homes. We have a lot of homes that are particular to one culture or religion. So we haven't built up a model that just suited one environment. So why did we look at starting the DAISY? Well, I mean, most people are aware now that historically we had a problem on palliative care and end-of-life speciality input for people that had malignancies. There were rigid limitations to response if it wasn't patient-centered, and the CIHI had done some interesting data collection and actually shown that the majority of people who were not under palliative care actually had their most interactions with acute in their last 6 months of life. We started looking at KCC and realized that the 51 deaths in an 18-month period, 14% died in acute, 1 person died in an ambulance on the way to acute, 14% within 2 weeks of return from an acute stay, and 42% of all the residents that died had at least 1 transfer to ED in the last 3 months of life. Some of those had several. So we knew there was a problem, because looking at what people really, really want is people tell us they know they're seriously ill, they're having treatment, but they actually want to have that quality of life right up until the end. And 80% say that they would like to talk to their doctor about end-of-life care and the things that matter to them, but actually only 25% do. So we used a lean project to actually identify the problem, and one of the reasons that we understood the failings from the initiation of the project in another site back in 2010 was that we very much went with a historical paternalistic model of trying to solve a problem, and that was us as healthcare providers deciding what the problem was and how we were going to solve it. So what we actually did, we went to clients, we went to residents, we went to families, we then went to the staff who were working on the ground, and we actually used Lean to do a high-level mapping, value stream mapping, to figure out where the gaps were, what we were currently doing, what people wanted, and what we actually needed to do to fill that gap. The root cause was that 77% of people had not been identified as being at end of life before they died, and they'd never had a conversation with anyone. So using that voice of the customer, we built a working group, we brought everybody together, and we started mapping what people told us they want, understanding the process from admission to the death of a resident, understanding the process of the family's view of how that went, and started to look at what we could do to change it. So we came up with this model. We call it the EPAC house, and it is very much looking at the 4 pillars that were really crucial in delivering what people wanted, their wishes, their values, their goals. So the first one was understanding that the staff did not have the capacity or the confidence to actually start having conversations, understand how to identify the people that the conversations should take place with, and also what was the conversation about. We also realized that clients, residents, families, they needed much more knowledge, much more education regarding what palliative care is, their disease trajectory, and also what did we mean by goals of care, because most people that we spoke to had thought goals of care were about completing their degree of intervention. We then also noticed that the psychosocial care was missing in many, many cases. One thing I want to say is that end-of-life care is very, very well done in residential care. But when we look at end-of-life care, we're talking about the last week of life, maybe the last 2 weeks. And what we know from talking to residents is their end-of-life care journey starts much, much earlier than that. We also started to talk to residents who were actually witnessing increased death. We know that people are a lot sicker when they come into residential care. We're having a lot more deaths in a year. And the residents who are surviving are watching that happening, but they're not actually getting the psychosocial care. And then the other big voice we heard was from the teams who felt that they weren't supported when they lost residents who'd maybe been there 10, 15, 20 years, or even those residents that came in for a very short time and they were really struggling to manage the conversation when nothing had happened, and they needed a bit more support. So underlying that is metrics, reporting, what is the current state, and then constantly looking to see how we're doing and doing just-in-time correction or education. And if I move on to the next slide, you will see the actual plan we kind of came up with how we were going to fulfill our EPAC house. 3 main things that are terribly important, and in no particular order. We put them in this order to make it easier for people to have some way of moving through the process, but sometimes this order changes. The first one is identify. The second one is discuss. The third one is plan. So we call it IDP. Now, I have seen a lot of models that focus very much on the identification. How do you identify all those people that need a palliative approach? And we use things like the SPICT, the frailty scale, the dementia trajectory, the surprise question, would you be surprised to hear this resident had died in the next 6 months to a year? And then people are identified and then nothing actually happens. The key to this model is the conversation. Absolutely central. Nothing happens unless you have the conversation. So when I look at identify, what are we identifying? We're identifying the people who should be a priority to start those discussions with. We're also identifying what the journey is going to look like from here until then, because that's the big piece that most of us miss. We talk about where we've come from and what we're currently doing, but a lot of families tell me they never knew what was coming up front. So we use the future challenges. So having that discussion is important, teaching staff, what is empathy, how do you use it, what are the basic 4 questions, and we have put those into 2 simple questions. There are 3 that you would ask a client. First one, what do you understand about your condition, diagnosis, state of health? Second one, what are your goals? What are you hoping for, or what do you value? What keeps you, waking up every morning and feeling excited for the day? And then the last question, number 3, is what is your greatest fear? What are you worried about? What is the worst thing that you can imagine happening? And then we added a 4th question because we realized that the substitute decision makers were really struggling with the answers of these questions. So if we're talking to a substitute decision maker, we then say to them, thank you for answering these questions. If I was able to ask your mom and she was able to respond to me, would she have given me the same answers? Once you have got the answers to those questions, then we come up with a plan. And the plan isn't medical order for scope of treatment. It's not degree of intervention. It is what are the priorities that we should focus on for this client? Is it pain? Is it keeping their social interaction? Is it their mobility? And providing them with education to help them understand what is going to happen to those things they value and where do we want to focus on. So for example, if someone says, I love my food, I really enjoy eating, having a conversation to say, these are the things we're going to concentrate on now, but there may come a time when eating becomes problematic. At that point, what are your favorite foods? What are the things that we're going to do to really encourage you to eat? So how do we actually know it's an improvement? Well, EPAC focuses on what matters to the customer. So we focus on improved outcomes by listening to the people. We have regular surveys that we provide to families, asking them either just before the death when they're sitting waiting in a room, in the bedroom with the client, there are surveys available, asking them, did we talk to you early enough? Did you have access to all the information you needed? Was the palliative approach brought in at the right time for you? We also speak to the staff to see how things go. We measure how many people are in emergency in the last 3 months before their life and the reasons that they were there for, especially those transfers where there was not an admission, because it usually means that acute could not do anything for them. We look obviously where the person died, and if there was a documented goals of care, to say what they really wanted. We also have physician feedback. We regularly talk to the physicians about how things went, and we look at how easy it is to actually have these end-of-life discussions with surviving residents, because once these conversations happen and this model is really embedded in the facility, then talking about death is no longer a taboo, and the surviving residents are actually joining in and telling what people want. So any questions so far? If you can type any questions into the chat box, I can try and answer those for you. No?
We have a question from Claudine Tremblay. So I'm going to read the question out in English, and the translator will translate it for those in French. So I'm in a hospital, and she's asking if the DAISY project touches patients that are in residential care.
So it's interesting because, so we have EPAS was developed for residential care. However, we have since adapted it, and we've called it IPACE, integrating a palliative approach by having conversations early within coastal region, and that is now in community and acute. I think the basic premise of having conversations early and what to talk about and how to move that forward is suitable for anywhere. It's just residential care was the easy place to start because your clients are in there for some time, although not always. Out of our metrics, we've actually seen that 12% of the residents that have been admitted in the last year across Vancouver Coastal Health sites actually died within 3 months. So, yeah, thank you for that.
Okay, it's Ilan speaking. I don't see any additional questions right now.
Okay.
Just a reminder to folks, if things come up for you, please enter them in the chat box. But I think we'll then turn it back to Jane to talk some more about the results that have been seen in Vancouver Coastal from the implementation of the model. So back to you, Jane.
Thank you. So what I do want to stress is that obviously it's difficult in healthcare to measure things, and we do look at transfers and deaths in acute. We look at hard stats, and it doesn't always give you the whole answer, but it is what we have to be able to measure. But I do regularly also, as I said, receive the surveys and also chat with staff and chat with families, and the biggest results to me is actually people's responses. But as I said, the metrics are really what everybody focuses on. So the first one I want to show you is the increase in documented goals of care. Now, documented goals of care doesn't necessarily mean they're respected, but when you put these together with the metrics of transfers, you can see that they are making a big difference. So when we started this journey, we had 161 clients or residents across 5 sites on the North Shore who actually had either been referred to the palliative care program or with documented goals of care, or just had the documented goals of care. And by January this year, we actually had 737. So that's really, really exciting. We also look at the timing of the goals of care and then compare that to the number of transfers or where somebody died. And what our metrics are now showing us, if you look at the graph in front of you, there were 147 transfers to ED by residents. So these were transfers that did not result in an admission. Along the bottom is the time from the goals of care until the person died in weeks. And on the vertical axis, you can actually see how many transfers there were. And what is telling is that the majority of these transfers actually occur when a resident has had the goals of care conversation less than 2 weeks before they die. And that is very typical of what happens generally before this model kicks into place, is that people wait until someone is visibly at end of life, they're thinking about starting terminal orders, and then they start having goals of care with the family. And at that point, the family have not had time to accept what is happening and usually are in an emotional crisis, and the knee-jerk reaction is, let's try everything, let's send them to emergency. When we've had conversations in advance and families are aware of what that looks like, and my famous quote that I kind of really keep in the back of my mind now is Atul Gawande, that he put, the way people die in the 21st century is ODTAA, one damn thing after another. But our families don't know that. But if they know, the residents know, everybody's on board with what it looks like, and the goals of care conversations start more than 6 weeks before somebody dies, then we see reduced transfers to ED. And exactly the same can be seen for death in ED. So again, 140 residents died in acute, and if you look, you can see that the majority of them died where their goals of care conversation had happened less than 2 weeks before they died. So overall, comparison of Q4 historically since the education began, you can see that there is quite a significant drop in the amount of residents that are actually now dying in acute. So 20% reduction comparing Q4 15-16 the year before, but 43%, which is only 9 deaths, but it's still 43% comparing Q4 14-15. We now actually have the data for the whole of the 48 sites. This is just the 5 sites on the North Shore. And when we look at the data for the whole 48, it really is quite significant. We then looked at comparing the entire year. So this is for, this one is for all 48 sites. And the historical cumulative metrics. So if you look, this is ED transfers without admission. What we do notice, the first year, the first 6 months that we start doing this project, we actually see an awful, what we see, a big rise in the amount of ED transfers without admission. But it isn't actually an overall increase in ED transfers. It is an increase in transfers without admission, but actual days in hospital go down, and that's because we also work with the emergency departments to help them understand what our residential care sites can look at, can cope with, can problem solve around, and the care they can provide to their residents, so that if someone is sent to hospital following a fall or for some other reason and there's nothing that the hospital can do, rather than admit them until they die, we actually ensure they get sent back to the residential care facility, because that's the staff, the home that the resident knows. So coastal urban acute reduction, you can see there the reduction in actual use of bed days in the hospital. Reduction of 150 days in the first year and 250 days in the first 2 years after the RC education. So that obviously is very important to the senior leadership team, especially when our hospitals are so busy. When I said before, metrics are not the only thing that tell us that there is an improvement. What we've seen happening at the sites is remarkable and heartwarming. So we had one site that actually made dignity quilts for each of their units, but it was the residents themselves that made the dignity quilts. They knew exactly what the dignity quilt is for. Before the EPAs, the site used to have people that had died going out through the back door. Now they have people going out through the front door the way they came in, which is what we heard loud and clear from the residents, covered by the dignity quilt. Several of these squares that you see were actually made by families who were sitting in vigil with their loved ones as they died, actually making a square to go on a dignity quilt in memory of their mom, their dad, their loved one. we see a lot more sites now having these comfort carts, and rather than just putting a comfort cart together based on what they think, they are actually asking residents and families, if you were dying, what would you like to have access to in a comfort cart? We have sites that are holding 1-minute silences and actually bringing all the other residents together when somebody dies who's been there a while, and the feedback has been really, really positive. So that's me, I think.
Thank you very much for that, Jane. We have one question in the that's been posed in the chat box that we'll maybe ask before we go ahead.
Okay.
So the question is, could you provide a concrete example of a goal of care for a resident and family?
So it's interesting you should ask, actually. I was called in to speak to a challenging family member. This is the ask that I had. Could you come and talk to a challenging family member because she seems to be in denial? So I went and met with this wife of a resident who actually had MS, and it was very clear that no one was really asking to break down what she was saying. So I said to her, what is important to you? And she said, I want my husband to get his independence back. So that's where the staff stopped and said, that's denial. I said, okay, so tell me what his independence looks like. And we broke it down into 3 very specific goals. He had been able to comb his hair, not with a comb, but with his own fingers. He had been able to use a spoon to feed himself, and he had been able to wash his own face if he was given a face cloth. That was what she classed as independent. So we put those down as goals, reachable goals, if that's what we actually concentrated on. And she was so happy. She was over the moon. She said, I know my husband's dying. I just want him to be able to do those simple things as long as he possibly can. So those are the kind of goals we're talking about. What is important to the family? What is important to the resident? What can we help continue as long as we possibly can that has meaning to the resident? Does that help?
Yes, the Claudine who asked the question has indicated that that answer has been helpful. Thank you very much. We have another couple of questions I think that we can take before we move on, and they're related. So there is a question around how you actually count completed goals of care. Is it more than just the completion of the form in BC that's called MOST? And then is there going to be, is there ongoing collaboration with BC Quality and with the Division of Family Practice in your project?
So I'll go to the first one. MOST is not a goal of care. So we do not count completion of MOST. What we say is that you shouldn't actually have a MOST until you've had a documented goals of care. So we have a very specific form that can be uploaded to something like Point Click Care, and the form actually, it just has spaces for you to be able to write what the answers to the questions are, or what the family have asked you, or what the resident has spoken to you about, or maybe document that they actually have a living will, or they have an advanced care directive that they've come in with, but mostly it's for those 3 questions. And it is kept in green sleeves. The green sleeves is just a green plastic folder, and it is kept with the degree of intervention or the MOST form, but it is the most important document because that gives you the direction for everything else. The second question is there ongoing collaboration? Yeah, so the divisions and I share metrics. We also not as much as I probably could hope for, but we certainly, I don't think the divisions would hesitate to reach out to me if they wanted anything, and I certainly wouldn't hesitate to reach out to the divisions. So it's not an ongoing active participation or collaboration, but it is still very much there, and I attend the regular divisions meetings, especially in Coastal. The BC Patient and Safety Quality Council, there is no active collaboration at the moment, no. Except, well, I say that, we do actively take part in the What Matters to You Day, which started last year and is being repeated this year.
Thank you very much for that, Jane. Just before we move on, just to let people know, there have been a couple of questions around access to the slide deck. The full recording of the webinar and the slides will be made available on our website 2 business days from today, and all registrants for the webinar will be notified when those documents are available, in case they're helpful with you, for you with your ongoing internal discussions about the collaborative. So I will just move forward a little bit now to Lan speaking, just to talk to you a little bit about the collaborative itself. So EPAC is a 16-month collaborative, which will kick off at a launch workshop in June of this year, and it will end in October of next year. While there may be other outcomes, the primary objectives of the collaborative are to improve capacity to provide end-of-life care in the location of the resident's choice, to improve the experience of end-of-life care for residents, families, and staff, to improve the ability of care teams to have those effective, timely goals of care discussions with residents and substitute decision makers, to reduce those unnecessary and often unwanted transfers to acute care, and just to build that overall quality improvement capacity. So why join the collaborative? Why work with us? There are a lot of benefits of joining the collaborative. Selected teams will receive seed funding, and we will provide support through a range of modalities. These modalities include the in-person workshop, which I mentioned, a series of webinars, the opportunity to engage in peer-to-peer networking, access to an online desktop for resources, and the networks that participate will also have access to expert faculty and coaches for one-on-one support with their individual project implementations. Some of the kinds of content that you can expect to be covered during the collaborative are having difficult conversations, providing grief support, using data to encourage and sustain change in your clinical practice environments, clinical leadership and mentorship, change management, measurement, and evaluation. The training and faculty support that we provide is in place to help teams succeed. And it's not only about this particular initiative, but that training and support also helps support the implementation of other quality improvement initiatives that you may engage in going forward beyond this collaborative. So the next slide shows you the model for this particular collaborative, and as with many initiatives, the collaborative uses a train-the-trainer model. Starting at the top, networks need to identify master or lead clinicians that can then act as trainers for the homes in the network that are participating in the collaborative, and then for any additional homes that could participate in subsequent implementation waves after the collaborative period is over, and that those clinicians who are those network leads would also be available to provide that ongoing leadership and mentorship for teams within the network. It will be important for teams to, as you're preparing potential applications, to consider how training expertise will be sustained in your region, for example, in case of staff turnover. The lead network level trainers then are training the champion teams that are identified by participating homes, and the home level champions in turn can support their colleagues in their improvement efforts. It's important that when you apply to join the collaborative, you have some sense of how you're going to spread this work. Your plan doesn't need to be completely in place when you apply. That's one of the things that our faculty and coaches can help you with throughout the collaborative, but you need to have thought through what it could look like. And again, we're here to work with you towards the successful spread of this model of care throughout your network. So we recognize that regions have different resources, that they have different existing relationships, and that there are also ongoing quality improvement projects in many of your regions and in many of your homes. And we know that the proposals that we receive will reflect that variability and will leverage the unique resources that are available to you. There's no one right way to implement this model of care. But in terms of the overall description of the network in the proposal, it should be consistent with the characteristics that are noted on the slide. This next slide just underscores that the training model is foundational to this collaborative and that regional and home level training leadership that is sustainable is so important in terms of achieving that intended outcome of embedding what is a philosophy of care. So moving on to how to apply, the information regarding how to apply is on the slide. The call for applications is now open, and you can go to our website to access those documents. Your network will need to complete an expression of commitment and submit it by May the 25th. Because the initial workshop for this collaborative is happening in June, the submission deadline, unfortunately, for this collaborative is not flexible. You're asked within the expression of commitment to attach any declaration of conflicts of interest. There is a prospectus document which is a summary of all of the information that you've heard today. It can be found on our website. It has all of the details of the collaborative, but if there are any questions, please don't hesitate to reach out to us and set up a pre-application call. We've already spoken to some teams, so don't hesitate. And I see we have one question that I could take now. The June workshop is in person, and it will be held in Ottawa. The workshop is actually being done in collaboration with another one of our collaboratives that's launching at the same time. And so we're going to have an opportunity to have a wide range of participants from long-term care homes across the country getting together, and are really looking forward to a very dynamic opportunity to spread information and to have homes sharing with each other. If your team is selected for participation, the lead organization would be required to sign a memorandum of understanding, and that outlines your team's commitments and CFHI's commitments to you. It's important because it's the agreement that allows us to provide seed funding. So when you review the memorandum of understanding, we recommend that your lead organization follow whatever its organizational processes are for signing legal documents, and if required, consult with any legal counsel, as would be your usual practice. Participating organizations should also consult with their communications departments with respect to any policies around public announcements. And again, if you have any questions, please contact us. A reminder, as is noted in the prospectus document, that if there are teams from Ontario that may be considering applying, they're encouraged to contact Julie Darnay at Hospice Palliative Care Ontario. And finally, a reminder that the expression of commitment form can be submitted in either language. And this slide is just the summary of the steps for the collaborative. So again, a reminder, applications are due on the 25th of May. Selected teams would be invited to an introductory webinar that we're going to try to plan in June, and then that in-person launch workshop, which will be held on June the 19th and the 20th. And that launch workshop will be open only to selected teams. The pre-implementation period will run from July to August, and during this period, CFHI faculty and coaches will support you as you plan for implementation so that in the fall your teams are ready to go. Over the course of the collaborative, we'll provide regular training through various modalities such as webinars, videos, podcasts, and other availability of other materials. Your network will be required to submit data monthly as we proceed so that we can track whether our change is an improvement. And you may be asked to participate in some qualitative evaluation, which could include things like surveys and interviews. The collaborative will end in fall 2019 with a results webinar where teams will share what has been accomplished. So that ends the formal slide presentation. We now have some time for questions and answers, and I see we have some questions in the chat box now. The first question is, how do we define a network? How many long-term care homes, etc.? A network we fully expect that the network will be different in different regions. We look to regions to reach out to partners that they may have worked with in the past, that they may be working with now, where there may be kind of logical quality improvement or other tables where homes may be working together. But that network definition we expect to look different in different homes. Experientially, if those networks are homes that have maybe worked together in the past, that can be really important in terms of the collaboration and the sustainability of collaboration. We also have a comment that, a question and a comment that the timeline for selected teams in terms of travel arrangements is short. Yes, it is short, but this is the planning for this collaborative. We have a question also around the workshop. Is it mandatory for in-person attendance? The kickoff workshop is a really important part of setting the stage for the collaborative. There's a lot of opportunity for coaching, for information, for working on that implementation plan. And not attending the workshop would be would put a participating team at quite a disadvantage. We have a question around funding. The seed funding that we provide as a part of the collaborative can be used to pay for travel costs to the workshop. Absolutely. I think that is all the questions that have been in the chat box so far. We have a few more minutes, and we can pause if people would like to take a few more moments. We can certainly take a few more questions, and I see some folks are typing, so we'll just pause and wait for the questions to come up. So we have a question from Kathleen. Who do we contact for a one-on-one conversation? You would contact me. It's Ilan speaking, and my contact information is on the screen in front of you. Email is a really a good way to reach me, and I would be happy to organize a phone conversation that is convenient for you. And if there are members of your team that you would like to have join that conversation, we can arrange whatever is most convenient and most supportive for your site. Susan has asked if the session is recorded. Yes, the session is recorded, and both the French and English recordings as well as the accompanying slide deck will be available in 2 business days on the CFHI website. And as registered participants, you'll receive notice when those materials are available to you. We can just give it a couple more minutes. We have 10 minutes left in the time block. A couple more minutes for additional questions. Okay, if there are none, we would like to thank you very much for your participation. We look forward to speaking with you. We look forward to working with you. And we have, before we go, just one final poll. There are a couple of questions on the screen in front of you. If you could take a few moments just to answer, that will conclude today's webinar. And we wish you all a wonderful day wherever in the country you are. Thank you.
This concludes today's call. Thank you for your participation. You may now disconnect.